Hi everyone. I think we can start. Dr. Girdhar has joined. So let me welcome you to another session of Jiva Masterclass. Today we have Dr. Puneet Girdhar with us. He is Principal Director and Head of Ortho Spine, MIS and Robotic Spine Surgery at BLK-Max Super Speciality Hospital in New Delhi. And today he'll be talking about spinal surgery, advances in technique and technology for excellent patient outcome. Dr. Girdhar, stage is all yours. Hi, Dr. Girdhar, can you hear me?
I just joined. Hello?
Yes.
Yeah, I can.
Yes, Dr. Girdhar.
Yeah. Can you hear me properly?
Yes, Dr. Girdhar, we can hear you.
Okay, fantastic. So just give me 1 second.
Sure.
Can you see my screen now?
Yes, Dr. Girdhar, we can see your screen, but no presentation. I can just see Zoom uh, workspace app. Yes,
Okay,
now I
now?
can see presentation.
Okay, 1 sec. I'm just sorting it out. Oh, 1 sec. I think. No, I need to go back onto this one. Um,
Dr. Girdhar, if you're speaking, you're on mute. We can see your screen. We can see your screen, Dr. Girdhar, but I think you are on mute.
yeah, now it's okay.
Yes, doctor, it's
Yeah,
perfect.
wonderful. Excellent. Sorry. Now is the screen okay?
Yes, doctor, the screen is also
Okay.
okay. We can see you also and we can hear you also.
Okay. I'm just trying to minimize the windows. Yeah, now, first of all, I would say good afternoon to everyone. I don't know what exact time would be there. It is
It would be between 12:30 p.m. to 1:30 or 2:30 p.m. in different countries.
fantastic. So, are we spread all around the Western Africa?
Sub-Saharan African, doctor.
Sub-Saharan, okay. So, I see close to 10 participants here, right?
Yes, Dr. Girdhar.
Okay, fantastic. So, uh, 1 second. How come this has maximized? Okay. So good afternoon to everyone. And should I go ahead and continue in English, or would you like to translate everything that I say after a slide into French or
Today we just have English speakers, Dr. Girdhar. All
pardon?
English. Today we just have English speakers, Dr. Girdhar.
Wonderful, excellent, fantastic. So I will just proceed. So just a small introduction about myself. I'm sure you've already been by the Geo group already you have been introduced about my specialty. I am Dr. Puneet. Can you see my introductory slide?
Yes, doctor.
Yes,
Yeah.
yes, yes.
Great, great, great. I hear some voices. Now it's alive, right? So I'm Dr. Puneet Girdhar, and I work as head of spine surgery at BLK-Max Hospital, which is a 650 bedded flagship state-of-the-art hospital from the entire Max Group in Delhi. And we have close to 24 operation theaters in the hospital. It's a massive place, and I run the spine show for them for the last 16 years. And I built up a center for orthopedic spine as well as robotic spine surgery and spinal deformity correction. So today I would be appraising most of you about how we have evolved in spinal surgery over the last 2 decades. Since I started practicing spine surgery, I have a sea change. What I used to do after getting trained as a spine surgeon 2 decades back, and today I've having performed more than 16,000 spinal surgeries. I can say that what I was trained on and what I do today are two different poles in spinal surgery. The basic principles may remain the same, but the technology and the techniques have completely turned around the way we look at any pathology in spine. So it has been. So today I run a department which is very well equipped, whether it is the spinal surgeons who work as associate or as uh, attending surgeons in my team, or we have a very evolved and something to be proud of fellowship national board program, which is a diplomat national board, one of the highest accreditation after a super specialty exam for postgraduates to enter into this course. So only close to 15 organizations in the entire country are accredited with this kind of program. And I have at a time training two fellows which are within a 2-year program.
Thank you. Bye bye.
Mm. So we have dedicated program
It is
manager.
fine. No.
Hello? Yeah. So we have a dedicated spine operating suite I will talk about. And today where we are at this organization and the Center for Spinal Surgery, I perform close to 1100 spinal surgeries every year. That amounts to almost 90 to 100 spinal surgeries every month. On an average, my theater list has minimum 4 to 6 spinal surgeries on one day, and I operate almost more than 20 days in a month. So that's a huge volume we are looking at. And I will also discuss the myriad of problems in spinal pathologies that we deal with, and the kind of patients which you would be encountering on a daily basis, where I think most of them are managed conservatively and being dealt with at the local centers. But many a times I will also refer to a case as a representative case of a lady I operated from Congo recently, where the things are progressed to an extent that patients start developing deficit, or the pain is intractable and not responding to conservative management, and patients need a specialized spinal center for surgical treatment wherever indicated. So this is our Center for Spinal Surgery and an entire team of spinal surgeons. My journey has evolved from open surgery when I was first trained. That's what I was talking about. If you see on the left side of the screen, the slide opening up the entire back is something I do very rarely nowadays. Most of my surgeries are done with minimal invasive techniques. Rather, we have moved recently in the last few months onto the least invasive endoscopic techniques. So I per se, you can call me fortunate or unfortunate, I don't know, but I am one of those generations who have gone through the entire journey of being trained on open spinal surgery during their training post-graduation program to where and what I do. I've gone through the techniques of doing these surgeries with loops, where I was worried about my own neck because the loops do not give you the liberty of a static image. So you keep moving your neck throughout the surgery to focus on your area of interest, while microscopes, as you see on the last slide, are today my workhorse every day. And they give me amazing illumination, magnification, coaxial vision. Today, any spine surgery training program, microscope has become a mandate, a necessity. But I have gone through that era, which may sound very ancient, where we did not have a microscope during my postgraduate training. Today, when I came back from US with my training with Dr. Kevin Foley, who has been the inventor of microscopic tubular techniques, I have been performing them since 2012. So close to 12 or 13 years, I've been doing all my surgeries wherever I can through minimal invasive microtubular approach, as seen on the screen on the left side. I will show you a couple of cases I have operated through the tube. Of late, we have started endoscopic work, whereby, of course, we understand the limitations. Endoscope cannot take care of all pathologies at all times, while biportal endoscopy is the recent addition, which can take care of 90% of your spinal work, because it works like any other laparoscope, like in your abdomen, or arthroscope in your knee, shoulder. It is in the fluid medium, unlike the abdomen. It's more like a joint scopy. So it works under the normal saline medium. And this fluid medium allows you two ports, one through which you can put the camera as well as the illumination source. And through the other, you can use your normal instruments on the spine like you use through your open or tubular approach. So this is something that you can take the liberty today to be able to perform through a biportal technique with this modern technology, and give patient the best outcomes with this least invasive approach. Mentioning just a case scenario to understand, and also this case tells us which patients need to be referred to a spine specialist once they are going out of hand and not responding. So a typical patient, 60 years male, radiating pain in the leg with inability to walk for more than a few meters. Over a period of time, he started having numbness in the foot. Some unfortunately develop a foot drop, but usually I like to intervene before the foot drop. So patients who have been on 4 to 6 weeks of medical management and has not responded at all should be referred to a spine specialist, or patients who are on conservative treatment and 6 weeks have not elapsed, but patient has started developing further symptoms or advanced symptoms like numbness, weakness, gait disturbances, and inability to bear the pain, should also be referred early. While this patient took 6 months of treatment but did not find great relief, he exhausted all physiotherapy and pain management injection therapies, but he was just worsening day by day. When I look at his MRI, I saw that he has been operated previously on the left side where ligamentum flavum has disappeared. Somebody has done a decompression procedure for him many years back, which worked for a few years, but unfortunately, he had a further collapse of his facet joints and the disc height also dropped. There was also a subtle evidence on MRI of listhesis. That means this patient is having progressive worsening on MRI. His spine is becoming unstable at L4, L5 level, which was proven on these X-rays done bending forward and bending backward. So whenever you have a back pain patient whose MRI shows some changes, if the back pain is very pronounced and patient says that from 0 to 10, I have pain more than 7, 6, 7, 8, one must get X-rays of lateral view of spine bending forward and bending backward. This gives us very important information whether the spine is stable or unstable. In this patient, in this particular case, the patient has L4-5 instability. So on bending forward, these X-rays show a slip or a listhesis, and on bending backward, there is some reduction back to normal. So the patient is scared of getting paralyzed with surgery because patients have seen bad experiences from their family and friends, and big open spine surgeries, which have been sometimes very debilitating if not done carefully. There has been damage to adjacent normal muscles, the facet joints and structures which are vital to patient's back strength and ability to maintain a upright posture. There are sometimes mismatch in expectations, so patient is always worried about, if I do the surgery my foot drop may not recover, so why should I do the surgery? Patient is also worried about subsequent procedures, and this will happen very frequently in our clinic, where patients will ask us all these questions. Of course it costs a lot sometimes to do bigger spinal surgeries, but at BLK-Max, at our spinal center with Dr. Puneet, the surgeries are very affordable, and I work very closely in association with GIVO to provide the affordable care to all your patients from Africa and do our level best to give them great outcomes so that they can fly back sooner than later. So while the patient is worried, today we are equipped with so many options. I put the open procedure, open T-lift procedure with red flag, something I don't perform in 1 or 2 level surgeries nowadays with this kind of instability or stenosis or disc problems. I always do minimal invasive in these patients. I will show you one of the recent patients I've operated. And this with minimal invasive technique, even with grade 2 listhesis, grade 3 listhesis, severe deformities also I can manage with minimal invasive. And today we also have the option of doing biportal endoscopic procedures to do these decompressions and stabilizations. So we all know that air travel is safer than car travel simply because of the advancements in technology like air traffic control and flight critical systems. The navigation itself gives us great ability today to look at the longitude, what we are doing in the air, to the extent that the statistics says that the odds of dying in a air transport or a space transport are 1 in 7,000, while the odds of dying in a motor vehicle accident is 1 in 100 in your lifetime. So air travel stands far more safer than car travel, despite the common perception that we may have better control in car travel. Similarly, as a spine surgeon, I may feel that I have more manual control putting my screws. If I don't use navigation or robotics, it is in my hands. But the data and the statistics show the opposite. It shows if you are objective in your approach, if you use navigation, robotics on an everyday basis, and you have a good backup, the outcomes are going to be 99.9% safe with all the technology. And it can be performed across the board by your team with the same precision, irrespective of number of years of experience. It will help you objectify it and make patients' outcome much safer in terms of implantation or hardware. But of course, you require much more skill to do a good decompression or reduce a listhesis, which a robo cannot perform. You also need your skill and experience to perform corrections and achieve good sagittal balances in your spine and be able to give them a pain-free life. So some of the work can easily be transferred onto the technology to make your life easier and patients' outcomes safer. So today we boast of, at our institute, we boast of having every possible technology on the planet to make spine surgery not just safe, but precise, accurate, and least invasive. So we use microscopic, I personally use microscopic tubular technique in almost all cases. Wherever I can do away with, unless there is a multi-level or a huge scoliotic kyphotic deformity which requires me to remove an entire vertebra, I would definitely use open approaches there. but I may still use microscope for aid. But all other degenerative problems, I deal with tubes. And I will show you the outcome of the patient. I showed you just now a 60-year-old man who was in trouble and was operated many years in the past with a decompression procedure, but now faces instability and needs fusion. I have to put a cage, screws, and I will do everything through a 20-millimeter tube. Sometimes I use 18-millimeter or 20, maximum 22-millimeter. That means 2.5 to 3 centimeter incision maximum for doing the entire procedure. I also use, as I said, endoscopic procedures. I will show you examples of the newer techniques of cementing, disc replacements, and sometimes spinal cord stimulators for neuropathic pain. But ethically, we don't use it for promising recovery from paralysis. We have advanced pain management techniques like nerve blocks and facet joint blocks, impar blocks. We also have the best technology on the planet, you name it, whether it is an intraop 3D CT or it is multimodal neuromonitoring, the microscope, state of the art for giving the best outcomes to the patients. I use ultrasonic bone cutters instead of hammer and chisel. And also it scores above the drills because it preserves very good bone at a very lower temperature. So that can be used as an autograft. It prevents us from taking bone from other places or destroying your bone with the drill. We also use radio frequency ablation in alliance with our pain management teams. And last 3 years, I have been using extensively robotics on an everyday basis in my patients to do the hardware work, the implantation work, putting screws in cages. And this has given me an extra edge to save a lot of time and make it more minimal invasive and precise most of my implanted surgeries. So as I said, multimodal neuromonitoring is our workhorse in all deformity patients. I need to see my SSEPs, EMGs, triggered EMGs, and motor evoked potentials throughout the surgery. It is mandatory in most parts of the evolved world to have this records as medical legal records while performing these surgeries, so that at the end of the surgery we have a record which shows if anything went wrong, how it was tackled with. While most of the cases you will not have any major problem, but it will keep you alerted throughout the surgery of any potential damage, or if a damage occurs, what are the reversible steps will be guided only by the neuro monitoring intraoperatively. So minimal invasive spinal surgery has great advantages: smaller cuts, preserves muscles, lesser pain, faster recovery. Most of these patients are walking next day. The usual stay of my patients is 2 to 3 days in the hospital. If I'm doing implantation, if I'm doing a discectomy, or if I'm doing a decompression for spinal stenosis, patients don't stay for more than 1 day. Next day, they are up and about and they're ready to leave the hospital without any previous symptoms. So the patient I showed you earlier was having instability. I did a T-lift procedure where I increased the disc height by putting a cage. I did a thorough decompression of the nerve on the side affected, and I did put in screws, which are percutaneous screws, through these two small cuts on the lower back, which are around 1.5 to 2 inches on either side, without disrupting the midline musculature. Our multifidus and erector spinae, the major stabilizers of the back, are preserved. There is no blood transfusion. The surgery takes 1 hour to 1.5 hours, and the patients are up about next day. Within 2 days, they are ready to go back home, and they don't have the same symptoms of sciatica or numbness like before. Their pain is largely taken care of. They may experience some element of back stiffness, which will be gone by 70 to 80% within the next 2 weeks. Look at this patient. Next day, he's walking around very comfortable. In 2 days, he will be back home, and he doesn't need any great physiotherapy. Just regular exercises at home are good enough. And this patient has no major cuts on his back. The small sutures or staples can be removed back home in their hometown or home country. So we get a lot of patients of lumbar canal stenosis. Patients will come to you saying, oh, they are 65, 70 years old. They used to walk 2 kilometers, 3 kilometers before, but now they can walk 100 meters, 50 meters, 200 meters. They have to sit down. They have a numbness, choking feeling in their legs. We know that we call this symptom as neurogenic claudication. So why this happens is because of lumbar canal stenosis. There is severe narrowing with age of the spinal canal and the nerves start getting compressed. So when these patients over the period of 2 to 3 months are not responding to our medical treatment, flexion exercises, physiotherapy, they need to be referred to be taken care of. And contrary to the past, what was done was laminectomy procedure, which was debilitating, muscle cutting, removing a lot of bone, and these patients would not easily stand and walk next day. Sometimes they would be in bed for a few weeks. That was bringing a bad name to the procedure, surgery, and outcomes. So what has happened is over the past few years, all this is being done with endoscopes and microscopes with tubular procedures. Like in this case, I've done a central canal decompression with bilateral root clearance. The entire procedures take 1 hour. See the end-to-end decompression beautifully shown in this video. And the nerves are so well delineated. This patient finds immediate relief after surgery. Same evening, he is sitting up, walking in his ward. Next day, she is up about and ready to go back home. And there is a small few millimeters cut on the back. And this patient doesn't even need, we can put absorbable sutures and they are ready to go home, shower next day. Amazing technology, amazing techniques in the past few years. Look at this huge herniated disc which has distally migrated. We all know the discs which fall down with gravity, distally migrated discs, huge in size, are very painful, and they usually trap the nerve going out of the foramen, and patients are in agony when they come to us. This requires very careful, meticulous, minimal invasive technique without damaging the distal joint, doing a decompression. We nowadays do it with a biportal endoscopy where you can put a scope through one port and you can put your all instruments through the other port, and the entire thing, see, is in a water medium, and you can remove this disc very carefully from under the nerve root, and next day patient is pain-free, walking around, going home without any trouble. See, these two small ports, couple of sutures, and the entire disc material out. 45 minutes to 1 hour procedure. No major complications at all. I've never seen a complication like this, like anything in this procedure. I've done thousands of them by now. Look at this patient. Young patients have, and nowadays we get patients who are computer professionals who have sitting jobs, desk jobs, sitting, we know, sitting for 8 hours now in literature is equated to smoking 20 cigarettes. It's very bad. Prolonged sitting can lead to disc herniations, disc degenerations, damage to our lower back by weakening our back muscles. Also, many people who have being influenced by the film industry to or sports industry to get curated bodies, work out in the gym without any training, and they lift heavy weight, their discs break. So one of those patients you are seeing on the screen, which I operated, next day is completely pain-free, no limp, no list, no pain, independently walking, ready to go home. So several elderly patients you will see, they come to you with a backache, especially post-menopausal females. Make a note, post-menopausal females have very high tendency to have osteoporosis. So they will come to you in the clinic and say, I have a back pain for several weeks. It's not going away with the regular painkillers, physiotherapy, massage, nothing is helping. You get an X-ray, you see a collapse of the vertebra. They have not fallen, they have not had an accident, but because of osteoporosis, weak bone, it collapsed because of a minor jerk or even without any trauma, and that leads to a collapse. In these patients, I do a procedure called kyphoplasty. We insert a balloon through a needle under local anesthesia. Make a point, no general anesthesia. Patient is awake throughout the surgery. Lift this fractured vertebra with the balloon, put in the cement, and see in this X-rays very clearly visible, the spine is stabilized. These patients can go home same evening because no systemic anesthesia is given to them. They are awake throughout the procedure. Immediate relief of 99% of pain, and at the same time, the ability to take a biopsy. And if there is a 1% chance these patients are having myeloma or metastasis, we don't know, they might be having a secondary pathology that gets tackled with the histopathology report. Just a small video to show how it is performed under local anesthesia. We throw into Jamshedi needles, put guide wires, take a biopsy, throw in the balloon, inflate 2 balloons, jack up the space, and the dead space is filled up with cement, which sets up within few minutes, and the patient is ready to get up from the operating table. This is the fastest procedure for pain relief in a fracture that has ever been invented. So cervical disc herniations are very common in patients, again with computer professionals, people who do a lot of driving because it puts an extra stress on their neck. So disc herniation, if it is not responding to conservative management or is associated with numbness, weakness in the hand, loss of grip, pinch, if they can't grab anything, that means it has gone beyond control. They need a surgery to remove this huge fragment. And all this is done with small cut on the front of the neck. And nowadays we do put in an implant which is mobile like a normal disc. It's a titanium implant. It gives complete mobility in all three directions, whether it is axial bending or it is rotation or it is front or backward loading. These patients have a normal range of motion, and the amount of stress on the adjacent level goes down, and they can protect their neck for a long, long time. It's a wonderful procedure with patients of good bone density and they are relatively young. So moving on to navigation and robotics, it increases precision and accuracy of spinal surgeries. A lot of literature, my own literature shows that we have been, last 350 cases, we have been 100% accurate in all our patients. Not accurate in terms of not causing any damage with hardware, but being accurate, being the bull's eye. If we play a dartboard, we know what a bull's eye is, scoring 100, the center red every time. So that's what robot can do. It can score 100 every time for you, provided you know how to use it. So this is a normal setting of a robotic procedure in my theater. It all starts with putting a frame on the lower back with an anchor in the iliac crest. Once you have that, you bring in your 3D C-arm. The 3D C-arm, the 3D C-arm spins around the patient's back and obtains 3D imaging, which is distributed on robotic software in 4 sections. One is sagittal, second is coronal, third is axial, and fourth is a 3D cut. The 3D imaging allows you to virtually pick up the spine model and rotate and see if you have planned your hardware well. You can drag and drop your hardware from the software, drag and drop your screws, cages, rods, and put it on the spine model on the screen the way you want the design to be. So you want entry point, trajectory point, diameter, length, everything you design, and bring the robotic arm in action. See in this slide, there is an intraoperative robotic arm in action. We have given a command, I want to put an L4 screw on the right side, and the robo aligns according to the planning in the same direction. The moment you start drilling, you can see a real-time imaging on the screen. Because it's a minimal invasive procedure, you can't see anything inside the human body, but everything you see on the screen is a real-time imaging what is happening in the body. And if you see, the blue is the one we planned. I will show you in the next slide, putting a screw. The blue is one I planned, and yellow is one being executed. It's moving, overlapping in all screens. Blue and yellow are overlapping end on. That's the kind of accuracy, 0.1 millimeter accuracy. Doing all this with robotics. No radiation throughout the surgery. Only the 3D spin in the beginning when there is no human inside the theater except the patient. For the patient, it's a one time. For your theater staff and surgeons, it's a safe procedure from radiation. Accuracy is close to 100%. You save a lot of time. You don't need so many shots and C-arm spins. Everything you are doing under navigation the under the guidance of AI of the software, you can see everything on the screen real time, and it tells you the exact trajectory and exact placement of screws along with length, if you see here, and diameter, the type of screw you want. It also shows the deflection if there is any. It also shows the trajectory. It's 27.7 degrees. So whatever you plan, you can do it for multi-level also. Nowadays, we also use expandable cages. So whenever there is a discal collapse and you want to restore the discal height, so you can put in your cages which can expand like this and bring in the normal balance by bringing in the curvature of the lumbar spine, which is what we want to reciprocate what patient was having before the pathology. So that's how it looks like after the surgery. You can very clearly see the trajectory of the screws looks like mirror images, and the mirror images only happen when you use robotics. Even in revision surgery, robotics is a great advantage. Somebody who has been operated in the past, you're not worried about finding landmarks or reaching the wrong scarred areas and entering the dura, because all the planning can be done from safe zones on a 3D screen. You don't have to navigate on the go. You can pre-plan it in a robotic software. So that's one step ahead. Navigation is gone by using AI for robotics, is you can pre-plan everything on the screen, pre-design it before actual execution. So in this particular case, somebody has done a laminectomy. So there are smaller areas to be planned and exploited to do a safe procedure, not to enter or slip in the zone which is previously operated. So see the mirror image again, robotics allows us two small cuts and the mirror image screws and cage to perform a TLIF procedure in a revision setting. So patients who have grade 2 listhesis, easily reduced, expandable cage, good discal height, and good sagittal, segmental, as well as global balance. Multi-level also. We also did India's first C1, C2 transarticular screw with robotic technique. Earlier, it was done with a C-arm imaging, and it was tough because bony elements are small and they are slippery. You can skive or skid on top of them, but with the robo, everything with the power drill, and there is a rigid arm. So we did this one in a C1 comminuted fracture. I plan to do a C1, C2 screw. I did the entire planning on the robotics, and the entire procedure took half an hour instead of 2.5, 3 hours would have taken doing an open technique and finding your landmarks. Here, you don't have to find your landmarks. The robo software will actually show you the landmarks. You just have to plan your hardware on the screen and then use a power drill to go through the same trajectory. So what we planned is what we could perform only with the help of robotics. See, it is going right through the center of the joint, C1, C2 fixation. Last but not the least, few slides on scoliosis and kyphosis correction, which is a spinal deformity seen either from birth or it is seen in close to puberty, which is 7 times more common in girls. Usually girls are affected with idiopathic scoliosis. And the third one is neuromuscular, seen in patients who have cerebral palsy or spinomuscular atrophy, where they do not find a sitting balance because of the lack of innervation of back muscles, leading to collapse of the spine. So 3 different types of scoliosis. One is idiopathic, more common in girls, seen close to puberty or before puberty. Second is congenital, where there is a birth defect. So one of the vertebra is half vertebra. It's called hemivertebra, and because of that, the entire spine starts tilting to one side as the child grows. The third one is neuromuscular, which are C-shaped curves. Look at this picture, C-shaped curves, because there is no muscle balance. The muscles have gone for a toss on one side, so the entire spinal structure is collapsing in a C fashion. So what are the screening and early warning signs that as physicians, as orthopedicians, as doctors, we should be able to detect? So first of all, whenever there is a complaint from a parent or a child, we need to lay bare the back and see the shoulders if they are at different levels. So They should ideally be at the same level when you make them stand and look with a horizontal gaze. If one shoulder is higher than the other, that means something is not right. If the head is not centered above the pelvis, head is centered to one side, that means it's a leaning tower of Pisa. That means something is not right with the spinal curvature. If there is a prominent hip on one side, patient is limping or one hip is more prominent, it's a sign that patient is having some sort of scoliosis. If the rib cage is, there's a hump at the back, the rib cage looks more prominent on one side, that means there is a thoracic scoliosis going on. If there is an uneven waist, no truncal balance, that also is a negative sign. We also should look for changes in the texture of the skin or overlying spine, on the overlying spine, like some dimples or hairy patches, color changes. They may be significant for a spina bifida, T-third cord, or a syndromic von Reckling-Olsen disease, where patient may have multiple problems with the spine as a part of the syndrome, or patient may have a spina bifida feature. Leaning of the entire body, as I said earlier, to one side is also a sign that patient is having a takeoff from the sacrum and the spine is shifting to one side. So what are the treatment strategies? If the curve is less than 25 degree and the patient is still not skeletally mature, patient is 6 years, 7 years, 8 years, 9 years, hasn't reached the puberty, which is like 12, around 12 to 13 years for girls and 14 to 15 years around boys. So those need to be observed. Sometimes bracing may help, though there are very controversial studies about bracing. So bracing has not got any level 1 evidence whether it helps or not, but psychologically, parents and children are comfortable taking one step further. But the moment their curves reach 40 to 45 degree, they require a surgical exercise. Nothing will save them from worsening once their curve reaches 40 to 45 degree and they are close to skeletal maturity. I'm giving you some examples of 5 or 6 cases which shows how a deformity presents and what should be done to treat it. So this girl is from Niger in Africa, and she came with a horizontal curve, a perpendicular spine, 90-degree curve. The cervicodorsal spine is flat and the lower one is going vertical. So why this happened is because when the child was around, she presented to me at the age of 10 years, but when she was 5 or 6 years, she had tuberculosis of spine. The tuberculosis did eat up one of the vertebrae in the middle, in the dorsal spine, and patient healed with anti-tubercular treatment. The patient continued to grow, but because now the one of the vertebra was missing, so it grew in the wrong direction. So there was a perpendicular curve growing and it appeared as a hump on the back. What happened to the patient is that patient's spinal cord was getting stretched on the internal gibbus. Patient presented with spastic paraparesis, weakness in both legs, and patient also started having urinary frequency and urgency, difficult in controlling. That's when patient rushes to you. And this patient was required to do a good decompression of the spinal cord, remove the gibbus, remove the entire vertebra in the front, which is pressing the spinal cord, and put in a mesh cage here and do a good correction, and followed by a physiotherapy. So this is one of the toughest surgeries in spine, where we have to remove the entire vertebra. This takes around 8 to 10 hours, sometimes 12 hours for this surgery to finish. It is called VCR, a vertebral column resection, and it is done only at advanced center. It is not performed at a center which does 2-3 surgeries in a month or 4-5 decompression surgeries in a month. It has to be done at a dedicated center which takes care of a huge volume, technology, both of doing all kinds of complex procedures, and has a team and an ecosystem to support it. But life-changing procedure for the child. Look at the 1-year follow-up. She came on a wheelchair. I wrote she was wheelchair bound before the surgery. And now look at where she has reached. Very good correction. She has got independent ambulation without any walking aid, and also has good urine control over a period of 1 year. She actually improved markedly in the first 3 months, but she came back to see me in India after 1 year. That's when we made this video for her. So other patients, early onset scoliosis, which are syndromic. So there are children who has curve around 70 degrees. Kyphosis, 70 degrees scoliosis. So both deformities in the same child. Scoliosis means sideways bending of the spine. Kyphosis means a hump on the back. So both deformities, but child is too small for me to do a full procedure. So I have to resort. These are syndromic children. They may be 10 or 12 years, but they will look like 4 or 5 years. So I did a growth rod here. This is a rod which will allow the curve to expand. It's called growth modulation. The curve to expand and the height to increase while correcting at the same time. So this guided modulation has to be carried till the child reaches 13, 14, or 15 years of age. And then this child has to be taken care of and final fusion has to be performed. At this moment, I think the child is 6 years. So it's a syndromic child, 6 years. And this patient required growth rods because I cannot do a final fusion at the age of 6. Another child who was operated somewhere else, somebody did this lumbar fixation, which I couldn't make out why and what it was done for, because the curve was above it and it worsened. It reached 100 degrees. When we did the correction, it took me 10 hours to do a revision in the scar, take it up. And I could reduce from 100 to around 20, 25 degrees and could give a very balanced shoulder. And the appearance came close to normal on the surface. These patients require very complex asymmetric pedicle subtraction osteotomies, which can take 3 to 4 hours extra. But most important, the signals are okay at the end of the surgery. We're always worried about the signals in revision surgery. All these surgeries, cosmetic surgeries to correct patients' back are only worth if you retain their neurological status. Other patients which are easier for us, like scoliosis like this, thoracolumbar scoliosis, corrected properly and completely, and children look normal after a few months. Other patients who have a hump like this, corrected, look at this before. There is an acute hump and completely corrected after the surgery. Then we have sprangial shoulder where there is a cervicodorsal deformity close to the neck. Look at the scoliosis and kyphosis. Both deformities are present in the same patient. We did a vertebral column resection. Took me 8 hours to do this entire procedure. It may look very small, but the precision requires ultrasonic osteotomes, removal of the entire vertebral body, two lamina, decompression, stabilization, while at the same time maintaining the integrity of the neurological status. One of the most complex procedures I've done in a neglected kyphoscoliosis. So this child had hemivertebra at the age of 4 to 5 years. The learning for all of us is whenever you detect all the signs I told before, whenever you detect a hemivertebra on an X-ray, either reported or seen on the X-ray, that patient, the moment they turn 4 or 5 years of age, should be immediately referred for correction. The surgery will be only 2 to 3 hours, and from next day onwards, the growth will become normal. We can remove that small hemivertebra and do a small correction and fusion rather than doing an extensive procedure if they come at 16 years of age. Like this girl, she came to me at 16 years of age with a very advanced hump, kyphotic deformity, and shoulder imbalance. So bad scoliosis, bad kyphosis, because there was a hemivertebra which was neglected. Either she did not know where to go, what to do in this case, or lack of awareness amongst all of us, the public, the community, the doctors, not knowing what to do in a hemivertebra. They are not referred at the right time for the correct surgery. And there are a lot of superstitions that the child is very small. There are also false beliefs that the child will improve by itself as they grow. So these are not true scientifically. They don't hold the ground there. So this requires a smaller procedure if they come at 4 or 5 years. But since they come very late, my 80% patients come late. Look at this, what happens to the adjacent vertebra. The global curve has now gone for a toss. There is a global malalignment in all planes. So I had to do a procedure which took me 16 hours. I did an extended VCR, an entire vertebra and half of another one, put in the cage there, put in a long segment fixation above to below, did a 3-level decompression here, and I used ultrasonic osteotomes, which allow us, this is a modern technology which allows us precise cuts like a pen. So you don't have to chisel the bone, you don't have to destroy the bone, you don't damage your nerves, you don't damage your pedicles, which are important for holding the screws. There is no thermal energy. With the moment they touch any neural element, neural sac, they stop because they're ultrasonic vibration based. They're not electric, and they don't destroy the bone like the bird does. So this bone, the entire piece can be used as a bone graft wherever required. So look at the final correction. Day 1 post-op with the central line still there and the arterial line there. This patient has been made to stand up in the ICU with a very good correction of shoulder balance and reduction of. Despite being very complex, the patient had great outcome because of the modern technology, experience, skill, the ecosystem to deal with it. More than 2 liters of blood loss in this procedure was dealt with our intensivist very well. So you need a great ecosystem to manage these patients. And last but not the least, she's standing up the next day with good neurology, no deficit, no weakness in the legs, no numbness, no nerve damage. Most important of all, whatever you do, you have to take care of their spinal cord and nerves. That is the duty of a spine surgeon. And I end my talk here showing a few pictures of patients I operated. They are from Congo. In the last, from the last winter till now, I have operated, I think, more than 12 or 14 patients from Congo alone. I've done maybe a few hundred from Africa, but some of the happy patients, I've put up the picture in the last 1 year or less. I've operated, and recently I operated on Miss Paulina from Congo, and she came in. Look at this X-ray, grade 3 slip, more than grade 2 slip. There is a lysis. The disc is completely collapsed. She was in excruciating pain, bilateral buttocks, numbness in the legs. When she walks, she has to sit down. Look at the kind of reduction we have got with percutaneous screws, minimal invasive, small cut, small cut, small cut, small cut, no big cuts in the middle. Everything done through the tube. Wonderful reduction, robotic implantation of screws, decompression, put a cage. Look at the distal height we have achieved. Look at this, no height and complete collapse. Look at the slip, L4 over L5, and all this has been reduced. And she's so happy 1 week from the surgery, going back home. And we are happy for her and her family that she can now live a normal, pain-free life. So these are my particulars anyways. I think I have to thank Jivo for the excellent work they are doing in the whole continent of Africa, getting these awareness talks, getting across to everyone there, making the technology and technique awareness reach every doctor, and helping the patients there. I have been grateful to them for their efforts that they are doing, and together we want to extend our services to everyone who is suffering with spinal ailments. From my side, I would be more than happy to offer the best possible that I can for patients who are under your care and they need advanced spinal procedures. Thank you very much, and I'm more than happy to answer any questions if you have.
Thank you, Dr. Girdhar, for a wonderful presentation. I'm saying thank you, doctor, for a wonderful presentation. It was very informative for me also, being a non-doctor.
You're welcome, welcome. Thank you for the opportunity.
Yes. Does anyone have any question? Also, doctor, we have Dr. Frank here, who's also the referring doctor for Paulina. He referred Paulina to you very
Hi,
recently.
doctor. How are you?
Hello, I'm fine, thank you, doctor.
Great, Dr. Frank. Thank you so much for sending Paulina all across and convincing her for getting a procedure to get her pain relieved. We feel privileged to be treating your patient, and I hope we have done justice to you, your practice, and of course, the patient.
Yes, absolutely. Honestly speaking, I was impressed by the recovery time for Madame Paulina. I was really, really impressed. And she's come back to Ghana and she's just always praising your team and always giving you praises
Thank
that,
you
oh,
so
she
much.
wish
I
she
think
had
that
come
is
for the
our
surgery.
motivation. That is our motivation.
Yes, yes, yes.
That
So
keeps
I'm
us
really
going.
proud of. Pardon?
That keeps us going.
Yes, 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 absolutely. And now I have even more patients who are also lining up to come and have
Sure.
a consultation with you and try and see if they can also come and have the surgery done. Paulina has been spreading the word over here and telling
Sure.
everybody how good the surgery was and how she wished she had come for it earlier because she's been in pain for years and she didn't know it was possible to get it done in a few days and then be walking again. So I'm really grateful.
We are equally grateful for working with you, and we are equally blessed to be able to serve your patients. I think at the end of the day, we all have one common goal. That is, we want to see our patients happy. I'm sure you will agree with that.
Yes, 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 yes.
Otherwise, you, me, and Jivo would not be here on a Sunday evening, leaving our family aside if we did not have this goal.
Yes, absolutely. Thank you so much.
Thank you. Thank you so much. Thank you to you for sparing your time and listening to my talk. I hope I didn't
Oh,
bore you enough. It was not laborious, and it. I
no,
hope
no, no, no.
you engaged. I didn't make you sleep.
No, no, no. I'm actually interested in it. I'm also trying to go into orthopedic surgery, and I'm really happy. I'm learning more about it and seeing the
Wow.
advances in the surgery that we are doing. So it's
Great.
uh,
Great. I
something that I
always
want to
joke
also
this.
engage
I
in.
always joke this to my orthopedic fellows. So I have orthopedic training program for last what 13 or 14 odd years, and
Oh, okay.
fortunately or unfortunately, again, I don't know, but not even one of them have opted for spine surgery as their career. They're very happy to do a knee replacement, arthroscopy, fracture, nail, because I think the spine surgery also has evolved so much that the moment they come into the theater and they look into the scope and everything is very tiny incision. So sometimes it can be a little discouraging that this looks very uphill. So I think last 4 years now, I have a fellowship national training program for spine fellows. So once they get selected and they come to me, they don't have an option to go to any other theater because now they are committed to spine surgery for the rest of their life.
Oh, I see. I see. That's wonderful.
Yeah, it's a little, see, it's always more inclusive and more I would say, in easier access to do something in an orthopedic theater where either a fracture is being treated with a plate, nail, there's a lot to do. But in spine, I think the level of confidence takes time for somebody to enter into the system and understand through keyholes what is going on. So it takes a little while. One has to be patient. It has a little steep learning curve because the margin of error is not there. And we cannot take any chances with our patients, whether they are fellows or associates. It's completely my responsibility. And I make sure that never somebody can mess around with your outcomes.
All right. It would be great if we have any questions. This is the right time to unmute yourself and ask Dr. Girdhar directly. Or if someone wants to interact with him, this is the time. Else, we can end this masterclass for the day.
Sure, I would be happy to answer any queries, any questions, any patient, anything you want to share, any patient you want to share today, tomorrow, later, anything that occurs to your mind about what you see. You must be seeing patients with a lot of backache in the OPD. Backache is it is across all specialties. You may be a gastroenterologist. I'm sure somebody will come to you with a back. Patient may be having a liver problem due to osteoporosis, secondary weakness, or lack of good musculature. Patient will have a backache. So backache is ubiquitous. It is something that we all will have in our lifespan. Are there any questions in the chat box? Should I see there's a chat box, couple of things going on?
They're just thanking you, Dr. Girdhar
Okay. Thank you so much. Thank you.
and Dr. Abebe.
Yeah. Hi, how are you, Dr. Abebe? You can unmute, we can talk.
Dr. Ananapal, you can also unmute. You can talk with Dr. Girdhar if you want to.
Let's have a chat. Let's discuss things. Let's discuss life. Let's discuss Donald Trump. I think he is taking more coverage than anybody else now, nowadays. The
Right.
entire media coverage is centered around him. He's making everybody else jealous. Oh, we have another chat.
Dr. William, are you trying to speak? We can't hear you.
Yes, can you hear me now?
Yes,
Yes,
Dr.
we can. Who is this doctor? Can I see all the tiles here? Oh, I think some network issues going on. Dr. Ishetu.
All right. Thank you. I think then I would like to thank Dr.
Yeah,
Girdhar
some
for
network issue. Yeah.
your time, especially on a Sunday evening here in India. Thank you very much.
No
And thank
problem
you
at all.
for joining this masterclass with Dr. Girdhar. If you have any questions, feel free to reach out to us in your work groups, and we'll be more than happy to answer it back for you by Dr. Girdhar. Thank you, everyone. We will meet again next week with a new specialty and a new masterclass topic for you. Thank you.
Thank you, Dhruv. Thank you, everyone. Thanks a lot. Really appreciate